This is a case report on pericardial effusion and atrial fibrillation. A pericardial effusion is excess fluid between the heart and the sac surrounding the heart, known as the pericardium. In most cases, inflammation of the sac, condition called pericarditis. When inflammation of the sac causes a pericardial effusion, the main symptom is chest pain. Large, serious pericardial effusions or smaller ones that develop quickly may cause symptoms that include shortness of breath, palpitations, lightheadedness, or passing out, cool and clammy skin. A pericardial effusion with these symptoms is a medical emergency and may be life-threatening. Case report. This is a case of a 66-year-old female who came in on September 25, 2020 with chief complaints of 1 week new onset, progressively worsening shortness of breath and dyspnea on exertion for 6 days, associated with increased lower extremity swelling, decreased urination, and stated going in and out of atrial fibrillation. She was found to have a large pleural effusion on CT scan and echocardiogram, hence admitted. Pericardiocentesis was performed and a volume of 1,600 ml of bloody fluid was aspirated. The drain was then secured to skin, connected to a negative pressure drain bag, and sterile dressing was applied. Laboratory tests pertaining to the pericardial fluid was ordered, aspirated fluid, and sent to the laboratory. Chest CT scan was performed on September 26 and showed results of no cardiac tamponade physiology, no pulsus paradoxus. However, positive for pericardial effusion with etiology unclear, possible new onset of congestive heart failure, worsening atrial fibrillation or subclinical hypothyroidism. Patient was discharged on October 2, 2020 with home health instructions. Past medical history: hypertension, hyperlipidemia, and atrial fibrillation. Diagnosed in 2014, she underwent a cardioversion in 2015 and cardiac ablation in October 2016. Medications: she was previously on amiodarone and was discontinued in May 2019 due to hyperthyroidism, and currently rate and rhythm is controlled with metoprolol and propafenone. She is allergic to compazine. Final diagnosis: pericardial effusion and atrial fibrillation. Conclusion: the early reports in the English literature showed that atrial fibrillation was uncommon in acute pericarditis and was associated with underlying structural heart disease of the myocardium, valves, or coronary arteries. It is also known that PQ segment depression, a marker of atrial pericarditis, is associated with the occurrence of atrial fibrillation in acute Q-wave myocardial infarction. A small prospective study of subacute pericarditis shows that atrial fibrillation may be common in tuberculous pericardial effusion associated with left ventricular dysfunction and high N-terminal pro-brain natriuretic peptide levels. Pericarditis associated atrial fibrillation is a transient condition that remits spontaneously within 6 weeks of treatment with anti-tuberculosis medications in patients tuberculous pericardial effusion. By contrast, chronic constrictive tuberculous pericarditis is associated with persistent atrial fibrillation in 8% of cases and usually occurs with a calcified pericardium. That ends my case report. Thank you very much.